Good morning, Dr. Smith, and morning to the rest of the team. For today's clinical explainer on rounds, I've got a new admission I'd like to present. We're going to walk through his progressive dysphagia, and as we go, I'll defend my reasoning for his underlying pathophysiology and lay out our immediate ward management plan.
Okay, just to give you a quick roadmap, I've structured this presentation into 4 parts. We'll start with the admission presentation, dive into the pathophysiology, go over my assessment and plan, and then wrap up with dispo and a few teaching pearls for the students.
Let's jump right into part 1, the admission presentation, and really look at the exact sequence of this patient's symptoms. So we're admitting a 68-year-old man whose chief complaint is food impaction. If we trace his history back about 4 months, he tells us that initially it was just solid, dry foods, things like meat and bread that were hanging up in his lower chest. But over the last 2 months, this has relentlessly progressed. He's now struggling with much softer foods. And absolutely crucially here, alongside this progressive dysphagia, he's reporting a highly concerning unintentional weight loss of about 15 pounds. Now, we know patients often mislocalize esophageal blockages to their sternal notch, right? Which is exactly why the chronological timing of the swallow is a far more reliable indicator than where they actually point. He points below the sternum, but more importantly, he has absolutely no trouble initiating a swallow. There's no drooling, no coughing, no nasal regurgitation. He also completely denies odynophagia, no pain with swallowing at all. And that's really helpful because it successfully argues against infectious etiologies like Candida or HSV, as well as pill-induced esophagitis. His history is pretty notable, though. Decades of untreated heartburn, a 40-pack-year smoking history, and regular alcohol use. As for his physical exam, it's completely normal. He's thin but well-appearing, intact cranial nerves, no neck masses. But let's be real, a normal exam here is entirely non-reassuring. We can't evaluate the distal esophagus at the bedside, meaning occult structural disease is highly likely despite his benign outward appearance. So when I was evaluating him in the ED, my primary organizing question was just trying to determine exactly where and when the swallow hangs up. Basically, does he have trouble getting the swallow started, or does the food get stuck seconds later? Getting the answer to that completely bifurcates our entire diagnostic tree. Oropharyngeal dysphagia means the patient just can't initiate the swallow. They drool and aspirate immediately. But because our patient has a total absence of immediate aspiration, drooling, or coughing, we can confidently eliminate an oropharyngeal neuromuscular etiology. His initial swallow works perfectly. It's only seconds later that he feels the food stick. So this safely and cleanly moves our focus strictly down to the esophagus. All right, moving into part 2, the pathophysiology deep dive. To really understand his deficit, we need to step back and appreciate the physiological complexity of a normal swallow. It's not simple. It requires strict neural coordination starting all the way up in the medulla. First, you have the oral phase, which mechanically forms the bolus. Second, during the pharyngeal phase, the upper esophageal sphincter opens while the epiglottis strictly protects the airway. And finally, in the esophageal phase, a primary peristaltic wave of smooth muscle contraction in the lower 2/3 of the esophagus pushes the bolus down. And obviously, this has to be perfectly timed with the precise relaxation of the lower esophageal sphincter. When that goes wrong, I like to categorize esophageal dysphagia into 2 distinct failure modes. It's either a structural blockage, meaning the physical lumen of the tube is narrowed or obstructed by some space-occupying lesion, or it's a neuromuscular failure. In that case, the tube is wide open, but the peristaltic wave is broken, or the sphincter just refuses to relax. So, applying his specific history to this framework, I use 2 master discriminators, solids alone versus solids and liquids together, and intermittent versus progressive symptoms. Look at our patient. His progressive, solids-only symptoms point strictly to a fixed mechanical block. A solid bolus physically cannot pass the narrowed lumen, but liquid still finds its way around by gravity. Because it's progressive and not intermittent, this allows me to confidently rule out something like an intermittent Schottky ring. And because liquids pass easily from the get-go, we can completely rule out a primary motility disorder like achalasia or scleroderma. This history basically hands us 2 prime suspects for this progressive structural block. First up, his decades of untreated acid reflux. That acid continually denudes the squamous epithelium, setting off a vicious cycle of severe inflammation and fibrotic healing. Over time, that lays down thick scar tissue, resulting in a benign peptic stricture that physically narrows the lumen. However, we have to consider the alternative. That exact same chronic reflux, especially when combined with his heavy 40-pack-year smoking history, could have driven a parallel myoplastic pathway. The acid stress induces Barrett's esophagus, which is that squamous to columnar metaplasia, and that can silently dysplasticize right into a malignant esophageal adenocarcinoma. So, structural or neuromuscular? Based on everything we just broke down, my definitive assessment is that we are absolutely dealing with a fixed structural obstruction, not a neuromuscular motility disorder. That brings us to part 3, my assessment, plan, and urgent workup. While we are highly confident this is a structural esophageal issue, his presentation is loaded with severe red flag alarm features. He's over 60, his dysphagia is relentlessly progressive, and that 15-pound unintentional weight loss? In the setting of progressive solid food dysphagia in a heavy smoker, that is an absolute mandate for an urgent malignant workup. We cannot sit on this. Because of those alarm features, my proposed first step is an urgent upper endoscopy or EGD with biopsy. I justify EGD as the mandatory primary step here because it's literally the only test that achieves direct visualization of the obstruction, tissue sampling to actually differentiate a benign stricture from cancer, and potential therapeutic dilation, all in the exact same session. Now, you might be wondering, why not a barium swallow or manometry first? Well, barium studies are excellent for subtle, intermittent proximal webs, but they cannot provide a tissue diagnosis for cancer. High-resolution manometry, on the other hand, is the gold standard for motility. It uses the Chicago classification to categorize the exact pressure topography of misfiring smooth muscle. But we only step down to manometry if the initial EGD is structurally normal, and we suspect a hidden motility issue like localization. It's just not our starting point today for this specific patient. So, based on what GI finds on endoscopy, I've prepared 2 distinct branches of therapy. And meanwhile, we're actively managing his baseline nutrition and aspiration risk here on the ward. Branch 1. If it turns out to be a benign peptic structure, GI will perform a balloon dilation to fix the immediate mechanical block. Following that, we'll initiate aggressive long-term acid suppression with a PPI to halt the ongoing inflammatory fibrosis and prevent it from recurring. Branch 2, however. If the biopsy reveals adenocarcinoma, we immediately shift gears to staging, and we'll place oncology and thoracic surgery consults right away. Finally, let's wrap up with part 4, disposition and some teaching pearls. For the students on the team, I want to highlight a massive diagnostic pitfall you need to watch out for. A Zenker diverticulum is a posterior pharyngeal pouch, pretty common in the elderly, and it causes regurgitation of undigested food and severe halitosis. The strict clinical rule here: always use a barium swallow to image a suspected Zenker's before you ever attempt an endoscopy. Passing a blind scope down into an unmapped Zenker's pouch can easily perforate the patient's neck, and nobody wants that. Another critical pitfall is failing to biopsy an esophagus simply because the mucosa looks perfectly normal to the naked eye. We must always biopsy. It's literally the only way to catch an underlying case of eosinophilic esophagitis, or EOE. That's an allergic inflammation causing solid food dysphagia that is so often missed entirely if you don't get that direct tissue sampling. So I'll leave the team with these 3 high-yield clinical pearls to write down. 1. Never dismiss progressive dysphagia coupled with weight loss. 2. Always mandate a biopsy of a normal-looking esophagus to rule out EOE. And 3. Image a suspected Zenker diverticulum with barium before you ever let a scope near it. The stakes of really mastering this diagnostic framework truly cannot be overstated. A missed mechanical obstruction drastically alters a patient's survival chances. In an older male with a heavy smoking history and chronic reflux, progressive dysphagia with weight loss is cancer until proven otherwise. For now, we've placed the patient on aspiration precautions, and we're just awaiting GI's EGD this afternoon. When those biopsy results return, they will dictate whether we're discharging him after a simple stricture dilation or if we're initiating a complex, multidisciplinary battle against esophageal adenocarcinoma. That concludes my case presentation. Dr. Smith, I'm happy to take any questions you or the team might have.